Good morning, dear colleagues. I am delighted to contribute to the COVID-19 therapies session. So my task is to talk about complement system and how we can modulate the complement system in the management of patients with severe COVID-19. So as a conflict of interest, I have to say that I'm an investigator for a trial sponsored by Alexion that is investigating the role of a monoclonal inhibitor antibody for inhibiting C5a. And this is currently under investigation for patients with severe COVID-19. So what we're going to talk about is the concept. The concept is that terminal complement pathway is very likely to contribute to organ failures and deaths from COVID-19. The opportunity relies in the fact that there are available monoclonal C5 inhibitors that we can try to use for modulating complement pathways. And the potential, of course, is saving lives. What the background first? As you know, we are facing an unprecedented pandemic. As per yesterday, there were more than 20 million people that are suffering from COVID-19, and roughly 800,000 people has died from COVID-19. So a global threat that we need to fight, of course. So sepsis is a clinical phenotype for COVID-19, actually. So if one goes back to the sepsis 3 definition, it requests having an infection, having organ dysfunction as measured by a SOFA score of at least 2 or more, and that is called sepsis. Translating this to COVID-19, surely we have an infection, pneumonia related to SARS-CoV-2. And now we know very well that the severe form have impairment in lung function. Many of them have shock and acute kidney injury, and DIC is very common. So to me, there is no doubt that COVID-19 is a viral sepsis, and in some patients results in a viral septic shock. And so there are very interesting data. Here is from a group in Marseille in France, recently published in Nature, nicely showing that COVID-19 is characterized by a systemic inflammatory response that is triggered by the complement system. So in this graph, one can see in the top panels the concentration of CRP, interleukin-6, and CCL4 in healthy controls, HC, in patients with mild COVID-19, paucis symptomatic, patients with severe pneumonia in green, and patients with ARDS in red. So there is a parallel between disease severity and the level of circulating concentrations of these pro-inflammatory mediators. And in the bottom panel, in particular at the extreme right of a graph, one can see indeed that C5a levels are highly elevated in parallel with the severity of disease in patients who got SARS-CoV-2 infections. In the same paper, again, when looking at cells, one can see that there is activation and increased levels in neutrophils, and also activation of CD14 and CD16 cells. And one can see that the C5a receptor 1 in the graphs below are highly expressed regardless of the severity of a disease. So there is undoubtedly a role of C5a and the terminal complement pathway in the activation of inflammatory response during COVID-19. So basically, what that paper found is that COVID-19 and the worsening of a patient's condition may be related to a transition from an epithelial disease in the non-severe form to an endothelial disease that will be driven by the terminal complement pathway. So this is why we investigated the role of inhibiting C5 using the eculizumab as an emergency treatment for adult patients with severe COVID-19 admitted to intensive care unit. And now I'm going to present you the results from this proof of concept study. So the objective was to evaluate the benefits and risk of a C5a monoclonal inhibitor, eculizumab, in ICU patients with severe COVID-19 as an expanded access program. So from March 10 to May 5, all consecutive ICU patients with proven or suspected SARS-CoV-2 related pneumonia ARDS were included. Placement in the eculizumab group was based on treatment availability at baseline according to the expanded access program. So all consecutive patients receive eculizumab up to the drug ran out. So the primary outcome was survival to study day 15. Secondary outcome included 28 days survival, included the mortality rates and risk ratio at day 15 and 28, included mechanical ventilation and ICU-free days, improvement in oxygen status by day 15, evolution patterns of circulating inflammatory mediators, and lactate clearance. So at baseline, one can see that the two groups were rather comparable in terms of age, of gender, in terms of duration of disease before inclusion, in terms of severity of illness. If any imbalance, it was favoring the eculizumab-free group. For instance, the SAPS-2 score median was almost 10 points lower in the control group as compared to the eculizumab-treated group. Most of the patients were receiving invasive mechanical ventilation at baseline, and about 1/3 of patients were receiving renal replacement therapy. Regarding drug therapy, most of the patients were receiving prophylactic heparin. Hydroxychloroquine was also given to most of patients. 1/5 of the patients were receiving vasopressors, and antiviral drugs like remdesivir was, at the time the study was done, rarely available, so only scarce patients did receive it, and about 1 out of 5 patients did receive corticosteroids at baseline. Regarding the treatment effect, so we looked at the activation of terminal complement pathway, and one can see that after 1 day of treatment with eculizumab, there was a dramatic fall in CH50 expressed as percentages, with at day 7, more than half of patients resuming a baseline value for CH50, highlighting a huge consumption of eculizumab and depicting thus a highly activated terminal complement pathway. And one can see in the right panel that free residual eculizumab indeed at day 7 was almost nil in many patients. Regarding the primary outcome, we found a dramatic improvement in survival in patients with eculizumab as compared to patients without eculizumab. There was no censoring here. All the patients were followed up to 28 days, so no censoring. It's important to say at this point. Regarding improvement in oxygenation after 2 weeks, one can see how dramatic was the improvement in oxygenation with eculizumab, with many more patients shifting from severe hypoxemia with a PF ratio below 100 to a BF ratio above 100 after receiving treatment. Looking at the number of lab variables with general linear model, one can see here that eculizumab resulted in a faster increase in platelet counts, also resulted in a significantly greater lactate clearance as compared to the control groups. Regarding cytokines circulating in plasma, here again was a substantial benefit from eculizumab. For instance, one can see that the level of interleukin-6 fell down faster in the eculizumab-treated group, as well as interferon alpha-2 levels. Regarding serious adverse events, this is a downside of a cone or the dark side of a moon, if you wish. There was a significantly higher proportion of patients in the eculizumab-treated group that had ventilator-associated pneumonia. And this was remarkable, and the only remarkable serious adverse event that was observed in this expanded access program. So in conclusions, patients treated with eculizumab had improved survival, accelerated lactate clearance, accelerated improvement in platelet counts and oxygenation, reductions in pro-inflammatory cytokines. Eculizumab-associated changes in complement levels, laboratory values, and biomarkers were consistent with terminal complement inhibition, with reduced hypoxia, and with decreased inflammation. And safety findings were consistent with adverse events that are reported in critical patients treated in the ICU, such as ventilator-associated pneumonia, albeit occurring at a higher rate in the eculizumab-treated group, and also adverse events were those known with eculizumab in complement-mediated disease, like, for example, myasthenia gravis. Thank you very much for your attention.